Okay, thank you very much. This relaxing exercise was right on time for me because I was sort of stressing out in the back. Please excuse my English. I'm sort of still jet lagged, but I'm very happy to share some of my experiences on what we have developed over the past years at the University of Amsterdam. We used the concept of design thinking to apply interdisciplinary healthcare education projects. So I haven't got too much experience on subjects related directly to stress, but I think we will touch upon some of the subjects that are important to addressing this as well. So what was introduced before is that obviously the healthcare environment is changing really quickly, and that it's more and more important for healthcare professionals to be able to adapt to how the system is changing. So times are more uncertain, knowledge is becoming more uncertain, and there are also all sorts of new players introduced into the field. So I think for if you really want to prepare healthcare professionals to cope with uncertainty and to cope with stress, you really have to teach them how to adapt to new situations. And this is also some of the things that I think design thinking is very useful for, because it is really about teaching you how to, how to influence your environment. So in this context, I always really like this quote, because I think if you are in uncertain environments, for me at least, the easiest thing to do is to really try to influence the environment and to design it myself. So I think in that sense, I always try to teach my students to sort of be able to understand their environments, try to find out where it needs to be changed, and then really to design solutions for it in order to prevent that everything is sort of coming to you, and you really have to cope with what someone else designed for you. So design. I don't know if some of you recognize this chair, but design used to be more about aesthetics. So, but more and more, design is now introduced as a method, as a mindset to sort of understand things, and it really includes topics such as problem-solving skills, gaining empathy with the one you're designing for. But also it's very much, and I think that's important in healthcare as well, it's also about collaborating with different stakeholders. It's about collaborating with your users, who may be patients, maybe families, maybe your colleagues. And it's, in that sense, it's about collaboratively designing systems, products, services, and it includes all sorts of these kind of subjects. So what we did in Amsterdam is we developed a course, and this is a paper we wrote about it, and it really describes how we developed such a course. And if you're interested in and developing such a course as well, I recommend you to read this. But what we did was we developed this course, which was a 6-month project where students, MD students, psychology students, were teamed up with art students, and they were asked to design solutions for healthcare providers, for departments, for patient support groups, and they went through the whole process of design thinking in this 6-month period, and at the end they came up with solutions for those partners. So before I go into some of the projects we took up, I want to show you explain to you a bit more about what design thinking, at least for me, is. Sometimes you don't really know what you're looking at. You do feel that it's that it's not a very sustainable situation. People are stressing out at the workplace, or it's not really. The way you design your system is not really closely related to what the kind of care you wish to conduct to your patients. But it's really hard to sort of grasp what the actual cause is, and also where there are maybe specific points where you can change something. So I think design and design thinking is a method to structurally assess those situations and to reduce the uncertainty and more work towards a certain focus, designing prototypes, and finally designing a specific solution. So this is another version of what Mary Jo has already introduced. So this is these are the different steps of design thinking. And if you go on the internet, you will find a lot of useful materials and also different kind of ways of describing how you should go through design thinking. But mostly it relates to those three different steps, which are here presented as again as a linear process. But it is really about constantly reconsidering, does my solution really match with the problem that we actually came up of well defined. So the first stage is about trying to find out what is actually going on, who is your user, what is the problem, what is the root cause we should solve. And once you know that, you will go on to a phase where you generate solutions for this, and you go back to your users, and you sort of get feedback, and you mix and match all sorts of aspects of your solutions in order to get to a better final solution. And that is what the diverging and converging is about. So you first go very broad, you generate a lot of insight solutions, but then you go back to your user to sort of converge again to what is actually a very important leverage point in this problem. And then again, once you have a final prototype or a final solution, you will go to a phase where you try to design also how you should implement this solution, because often it's you can come up with very interesting solutions, but if it won't be able to implement in the existing system, it may be very difficult to have a sustainable change. So it's converging and it's diverging, but it's not as linear as presented here. So the first phase is the inspiration phase, and for me, it's always the most important thing is to obtain a certain problem statement and a user profile. So what is the core problem we are trying to address? And it should be like one very clear problem. And also, who is your user? Who are you designing for? And you can use all sorts of things, including interviewing people. You can mind map. That's something I really like. Engage in participatory research. So, for example, our students would shadow patients, but they wouldn't start the moment they enter the hospital, but they would go start at the house of the patients to see how stressful it can be to have a planning with your clinician ahead, how difficult it may be to find the ward or the clinic. And all those things gain insights on how you may improve the whole patient experience and solve your problem, if that was your problem. So some of the pitfalls we often occur is that we are actually trying to find something we already thought of ourselves. So you only confirm the things you already defined, involving the most accessible groups only. So I think it's really important to also try to engage patients or users that may be more skeptic or maybe more hesitant or are from lower resources environments. And then also it is really about looping back to your users all the time. So it's not about, so now we ask the patients, we have all sorts of insights, and now we can do everything ourselves. No, you have to go back to the patients or to your users all the time to really test if what you concluded is really valuable. So this is an example of what research from our students look like. So the objective was to design a more humane psychiatric ward. So what the students did was they took like 3 spaces in this ward, and they designed one with the staff, one with the patients, they really tried to get feedback from why they would make certain choices. They stayed over at the ward to really feel what it's like. They went to a museum. They took surveys. They conducted interviews. So by that sense, you get a sort of comprehensive view of what was going on. And what they found was that the way the ward was designed was also a reflection of how they conducted care, which was not very structured and not super patient-centered. So what they came up with was this working station, which was a combined working station and coffee bar that sort of promoted informal interactions between staff and patients, and by that sense make the ward more humane and prepare patients for their life after staying at this ward. So ideation is about generating solutions. So the outcome is a solution to a specific problem. And what I would recommend you to do is to use really low resource ways of prototyping and brainstorming. So you would use just papers, cardboard, and those kind of things to get really quick and rough kind of ideas where you can get direct feedback from your users. So don't work on like very refined solutions. Really go back to your users very quickly and get their feedback. And you can use sheets like these to get structured ideas of what worked, what didn't, what kind of new questions or ideas came up, and how can we really combine our ideas. So this is one of the pitfalls, that you only test fully developed ideas. It's really a waste of your own energy, and also it's not very inviting to your user to give like really radical feedback on your ideas if it's already presented as a final idea. I think you shouldn't be too ambitious on trying to find one solution for all problems. And also in this stage, I think it's really important to go wild, and then afterwards you can also go back to in the phases of implementation on what is actually feasible and what the restrictions are. But there's always this one person in this brainstorm session which is giving the same feedback to all the ideas. Well, I don't think it's feasible. I don't think this is possible, and that's not really the kind of flow you want to have in your brainstorm session. So this is a home for early stage dementia patients in Amsterdam. And what you see here is a low resource co-creation session with dementia patients. So they asked people to make something that represented themselves, because the project here was to this home had a lot of resources to invite people and to welcome people, but they didn't really have any rituals to discuss losses, losses of your own ability, losses of people, and they wanted us to think of how they could deal with discussing losses. So this is, I think, is an interesting idea to make something with your users, because then you can talk over a certain object what someone's trying to express while making this, and it's not only like it's like a conversation, but you're also making things. And what their final conclusion was that they had this one moment of the day where they sat all together and they ate from plates, and what they designed was like a plate drawing workshop where patients could represent their own identity on a plate, and then once a week they would use those plates during lunch, and they would discuss people who weren't there anymore over those plates they ate from. So this is an example of another solution. Am I running out of time already? No? Implementation, it's important to have, like, if you want to have like sustainable long-term impact with your solutions, it's really important to also think of, well, how am I going to implement this solution? So, for example, you can think of a business plan or a stepwise implementation plan. For our students, we also train them, how do you pitch your idea, how do you present what you made and why this is so important to you. Another interesting thing is, I think, like a user journey. So you really map out all different steps of using your service or using your product. This makes it very visual when a product is introduced and which stakeholders are involved. And it could be like in terms of financing, it could be in terms of prescribing a certain product. You really know who to involve. The business model canvas, probably many of you know, but this is like a structured way of mapping all sorts of business-wise aspects of your idea. So the costs, the revenues, etc. Well, sometimes it could be difficult if you introduce a certain product, who your user will be. Will it be a patient? Will it be financing, like insurance? Will it be the doctor who prescribes the service? So this is also important to think of. Well, is it some new products need to be evidence-based before they can be introduced somewhere? And this is a product we developed for the Dutch market together with Johnson & Johnson, which is a recovery tool for patients recovering from serious mental illness. And this is an example of something we didn't do very well, to be honest, because we really designed it from I think a very interesting perspective. It was about positive psychology and it was about talents, but it was very difficult to get it implemented in healthcare institutions because of the not invented here syndrome. It's like, well, very interested you came up with this, but we rather develop our own systems. And then there were all those existing ICT platforms that were already running, and it wasn't feasible to include it. And there were people who had difficulties because of certain resources that had to be mobilized to introduce a new idea. And if it's not your own idea, you rather go for that idea you developed yourself. Going back to this course we developed, I think what I learned from this course, what students liked about this, is that they really learned to work in interdisciplinary teams, to work on solutions for real problems, and in that sense, it trained students to take on this lens, to really view during their clinical rotations, to take this same approach, and to get this agency, this ownership over your own curriculum, get this ownership over your own clinical experience. And the kind of resources we needed to get this thing implemented was interdisciplinary partners we collaborated with, but also faculty staff, because some faculties, it may not be very common to implement such a project in terms of get the credits secured. How do you assess the outcomes and stuff like that? But this is also something we described in the paper. So I think something to take away is that design thinking is a very structured method to collaborate with patients, with each other, to work on solutions. And in that sense, it provides agency among healthcare staff. And there's a lot of resources available online if you want to implement it yourself. Thank you very much.
So Tim, why don't you just stay up there for a few minutes in case there are questions, but I would actually like to open it up to the forum first and really invite you, has anybody in the room, ever used a process like this, within your own, organization? And if you could tell us a little bit about how you engaged stakeholders and went through a process like this, because I think, Tim talked about application in a couple of settings, but we're really interested in the forum today is applying this to improving well-being and resilience. So if you really were trying to think of how to do that in your organization, has anybody done it, or do you have some ideas? So Susan, you can kick it off.
Okay, because The design thinking approach is an approach. The methods are ones that we use all the time in anthropology. And it makes me think of a time when we did this in Panama with the health system, and they were trying to improve, they're trying to reduce stress, but also be able to improve staff-patient interactions in the system. And after doing the kinds of things you talked about, the observations, the informal interviews, the discussions with patients, discussions with healthcare providers, I think one of the things that succeeded was to get, for each clinic, we did this in several clinics, everybody in the room in a circle, from the clinic director to the guy who swept the floor, and generate conversations. We also did some role plays. We took scenes that we had observed and we had people act them out. Scenes of, for example, rudeness to a patient or a staff member talking down to another and hurting their feelings, and had people discuss these. But I think what was particularly, there were two things that were valuable. One was the role play aspect, putting people in the shoes of somebody who was experiencing something stressful through role play. And then the second was this equalizing mechanism of getting everybody in a circle to talk about what we were learning. And then, as you said, Tim, to generate the solutions, have that health community own the solutions for these problems.
That's a wonderful example. Thank you, Susan. I think I saw a couple of other hands go up. Okay, over here.
Brenda Zeeler, University of Washington. We used a similar approach, the design thinking, but also used liberating structures, which is an approach to hear all voices, and took a heart failure service line. They were having problems with communication, poor retention of nurses, high turnover, poor patient satisfaction, bad outcomes, and brought them together, did a baseline relational coordination survey to see how their communication and relationships were with each other, with all the different work groups. How does nursing and medicine relate? What's their ties? And then we stepped back and let them, we had lots of ideas of how they could actually improve the way they communicated and worked, but that had to come from them, because they were the end users. And so we asked them what they would like to do using liberating structures. We did this 25-10 where we asked them, what's your boldest idea for how you can improve the way your team functions? And you wrote down anonymously on a card what your idea was. And then we passed them around. You get up and shuffle. You do that 5 times, and you add up the scores. Perfect score would be 25. Then you read off the ideas, and it comes from them. It's generated by the end users, and they come up with ideas. And that's one thing we did. And then the what I need from you is the other thing we did with this group. It's the same thing. You get into a circle. Somebody represents medicine, nursing, pharmacy, the patient, social work, all the end users involved. And when they came up with the process they wanted to implement, they said, what I need from you is, and then they would ask the other profession. So what nursing needed from medicine was to show up at the same time every day before rounds. And then they had to think about it. Can they do that? And they didn't give the answer then. And then they came back around, and so the physician would go back and talk to the medicine group and said, can we show up at 9 o'clock? Or do we have to move our transplant meeting, et cetera, and come back, and then the question's asked again, and the answer is either yes, no, or I'll try. And so it was a way to really engage them, but the use of liberating structures in design thinking is very powerful.
Well, thank you so much for that example, because a couple of points that you made that were so important. One is when you engage the end users, they come up with the most relevant and sort of creative ideas. But the second piece is then they own it, which is huge. And that's so often an issue, I think, in change management when solutions are generated from the outside and imposed, and they don't often work. People are shaking their heads. Somebody else, I think, at your table. Yes. And please introduce yourself as well. Thank you. And as you're getting ready to speak,
just moving the microphone.
I'll just say if there's anybody in the adjacent room that actually has a question or comment, please come into this room and we'll invite you to speak as well. Thank you.
Maria Tassoni from the University of Toronto and the University Health Network in Toronto. So we use IDEO's rapid prototyping process a lot in our organization. We've used it to create new programs. For example, there was a desire to create an international center for education, so we used the design thinking process, bringing in various stakeholders to actually create a new program or unit in our hospital. We teach this method in our Collaborative Change Leadership Program, which is an executive program for leaders across the country. We've had some American colleagues there as well. So we've had projects there that a good example would be redesigning an ambulatory mental health program from 12 units to 4 units and using this process to do that. And then most recently, we had a request from our Ministry of Health for a 2-week turnaround on a massive proposal for a new program. And someone on my team said, why don't we use rapid prototyping? And I never actually used it to create a proposal, and it worked really, really well. So just to say, it doesn't have to be about a product or a program. You can use it for all sorts of things, from strategy to a proposal itself. One of the things, and this is a question for you, Tim, is in the model, there's kind of an implicit piece around evaluation and sustainability and thinking about that in the implementation phase, which from my perspective is a little bit too late. And so we've put on an overlay of developmental evaluation where you think about it right from the beginning. And when you've got that incredibly diverse group of users, to be asking questions throughout the whole process around, how could we implement this in a way that is most meaningful or makes sense? What are the ways that we want to build in evaluation and evaluation structures so we can learn and adapt as we implement? So that's a piece where we have adapted the process. And I wondered if you had any comments about the idea of building in evaluation and sustainability right from the get-go.
Yeah, I think this is also an interesting thing. I think from my experience, the design thinking method is sort of nested in the systems thinking approach. So you really have to. Well, I think by using design thinking, you can sort of focus on a certain part of the system, but you taking into consideration that you're part of a larger system makes your solution more sustainable. So I think that's also something the next speaker will focus on. But I think I'm sort of in a doubt, because you don't want to restrict your creative space by thinking too much about feasibility and long-term sustainability, because sometimes your system may need sort of a radical change. So if you don't want to only come up with sort of incremental solutions. So I think it's important to, while you're planning this process, that you really plan your evaluation according to the kind of problems you are researching and designing for.
And sometimes how I've seen it work kind of hand in hand is that people will do sort of the creative solutions, and so they'll be open and they'll brainstorm, but then they'll assign some criteria for evaluation. And, just adjacent to that, almost simultaneously be evaluating those ideas, looking at feasibility, sustainability, those kinds of issues. So back here, yes, thank you. And please introduce yourself.
Hi, Allison Whalen, Association of American Medical Colleges. So we've been actively using design thinking for the big problem of transition to residency, which is how you counsel people smart, how residents apply smart, and how program directors apply smart or choose smart. It is a big, ugly, complicated problem that is a pain point for everyone involved. And we specifically went to design thinking because it helped us to prioritize which of those to attack based on the user's needs, not our perceptions. And then once we decided what the priority areas are, again, using the users, it created some out-of-the-box thinking that we probably wouldn't have thought from the inside. And the other comment I will make is that we engaged a formal consultant group to work with us in the human design thinking, which was helpful in terms of teaching us, but I think more importantly, there have been a couple of the pitfalls that you pulled out. They kept us from falling into those pits, and specifically perfection before launch is something that I think anyone in academics and in associations, it's our nature. So that was, having the partnership with them has really kept us on track and keeping the true concept design thinking working.
Great, thank you. Simon?
Simon Fleming, resident from the United Kingdom. I'm very mindful that this is a really aspirational room full of people. You're what one of my mentors would call PLUs, people like us. So you all get it. My question is, how do you engage stakeholders who say, what problem? When you say, well, what you can do for me is stop using that negative language, or stop behaving in that way, or stop having X or Y, or do more of this, and they go, no, I think everything's pretty good, actually. Worked for me, seems to be working. Let's just carry on doing what we're doing.
Yeah.
Actually, Susan wants to address that.
Sorry. Susan Scrimshaw, I should say International Nutrition Foundation at Tufts. I should say quickly that when that happened at one point in my career, where I was looking at culture and pregnancy outcomes in women from different ethnic groups, and I went to the head of OBGYN at UCLA at the time, and he said the same thing, no problem, we're fine, everything's good. And then I found the head of OB, and he said, well, talk to my nurses and see if they think there's a problem. And they did. And so it was by going down enough layers in the organization that I got to somebody who would listen. And then we did the work, and then it worked back up.
So a good example of small changes and having large effects. Start someplace in the organization and watch where it impacts in other places. So we have time for one more, and I'll go back there.
This is not in the actual community-based, but a colleague and I just published in the Journal of Health and Healing about how to use this in teaching ethics, because historically people tend to look at it just with the head and not the heart. And so we, instead of having an individual just identify an ethical dilemma and write a case and then figure out which of the ethical frameworks would be the appropriate framework, we actually had them share that from a personal perspective. And then if one of the common one was issues around end of life, and particularly family members and particularly children. And so then we invited other people to engage in that if they had a child that age or whatever, and create literally almost like a role play. But it was for real because it came from an ethical dilemma that somebody brought to the class. And then we would prototype it with which of the ethical frameworks might have worked to address that issue. And it was very interesting from an interdisciplinary perspective how some disciplines migrate toward one ethical framework where other disciplines might migrate toward another. So it was, it just changed the whole dynamic from moving it to just a head experience of writing up a paper based on an ethical dilemma that I experienced alone to having it in a role play. So I think there are other ways that we use this rather than if we don't always have the opportunity to engage patients or people in the community.
Thank you so much, Patricia.